What's up, friends? Welcome. We got the original crew here. That's nice. That's nice. How are you guys doing today? Good. I'm seeing a couple of names I haven't seen, which is good. You guys have any initial questions? Anything?
Yes.
About what's up, Amy?
Yes, I do. Okay, so per your y'all suggestion uh, for more like medial hamstring stuff, for TRX like curls, supine where you like have your ankle, not your but your heels in the TRX like handles, and your back's on the ground, and you have a ball between your legs, and you're curling your heels inwards. I did feel like a lot of sensation, more so in the upper gastroc, medial and like lateral, like gastroc area. And however, when I did that same exercise with sliders, it wasn't as pronounced. But however, there was more sensation of adduction than there was in the hamstrings, at least for myself.
Yeah, Chris Beardsley did some research on how you target the medial hamstring. And that's your question, right? Like, how do we get more? Yeah, okay. Chris Beardsley did some research on how you target the hamstrings. And what they found is that when you're doing a hamstring curl, doesn't matter if it's TRX or like just a machine hamstring curl, if you have something where you are biasing more of like a toe in position, that is going to lead to more medial hamstring recruitment. So if you literally just turn your toes in theory, that should give you more medial hamstring recruitment. Another thing you can do is place some object in between your knees. That's what I like to do. So put like a foam roller or something like that, and that's going to give you more medial hamstring recruitment.
Okay, I did that. I did put like a ball between my knees. I felt a ton of adduction, like those adductors were just on fire. But so more toe in stuff.
Another thing is it would depend on the amount of hip extension you were in. So some people, I will notice that they're either in too much or not enough hip extension in a TRX curl. So for example, yeah, why not? If I'm on the ground here, let's just pretend I'm in a TRX. This is my couch. So some people will be like here, and they have like their low back against the ground, and then they're going to curl in from there, and that's great because that's going to give them hamstrings and not allow them to use their low back. Other people have stronger hamstrings than that, so they need to actually get up further here, but that also comes at the cost of them wanting to kick on their calves if they're too high because their hamstrings can't support that load. So they're either going to extend their back or use their calves a lot more. So it's a matter of starting low, going up, kind of like you're doing 90-90 hip flip, then you're going to feel your maximum hamstring recruitment. I would say go from there.
Okay, I think that's what I was doing. I was in too much like extension, like yeah, like I think I was just up too far. My hips were up too far. So this is really great because I have a client who has really bad hyperextended knees, and so anything to get those medial hamstrings, as well as for myself. So, but thank you so much.
Of course, of course. I know we had another question that I wanted to hit early on. It was in the questions today, and I figured it'd be much easier to talk about if we just did it here. And it's about the collarbone angle. Now, the collarbone angle is something that isn't really discussed a lot, but it's actually correlated to your infrasternal angle. And let me pull up my Instagram page here. I've got a post here that I think reflects this nicely. So I remember I was talking to, I think it was Jonathan, when we were talking on Monday. Now, gotta find it first. There we go. So I talk about this in the Energy System Development Week because
I think it's important as it relates to the archetypes we talk about in that week, but they're really just wide and narrow ISAs and how do you train them in terms of energy system development. So someone like me, I'm wide, and therefore I'm going to have a bigger predisposition to a wider collarbone angle. It's not going to be up on a slope like you see in this narrow guy right here. So with this narrow guy, you usually see someone who has a compressed anterior rib cage and also a narrow infrasternal angle. Those are going to be associated with each other almost every time. So because of this, they're going to have a poor degree of rib cage recruitment, or sorry, diaphragm recruitment. So they're going to want to kick on their neck, and they're going to want to use those scalenes, those SCMs, to help elevate their ribs, to help get air in. And then what happens is they pull up on the collarbones, which brings them together. So it's really no different than anything we've been talking about so far. And genetics obviously play a factor in this too. It's not just breathing is everything, right? But that's usually what's happening there. And then we're going to get into why that's important for energy system stuff later on. So with that being out of the way, what other questions you guys have?
With the collarbone then, mine aren't even, right? So my left collarbone sticks out. So if I'm doing power cleans, I always end up with a bruise on that left collarbone. Now that's also, I get pain in my left shoulder. Can that be in the same way as, I suppose, your ISA can be restricted in one and more up, that through compensations that left hand side is being elevated because it's having to breathe into the anterior piece and do its job versus what it should be doing, so to effectively lay it back down if you're expanding in the right places?
Yeah, I mean, I don't want to say it's always one thing, but you do see symmetrical collarbone angle just like you see an asymmetrical ISA, and it's often
okay.
Yeah.
Okay, cool.
Mm-hmm.
I've got another question as well. On the that staggered deadlift that you put the video of, so you got the rear foot toes elevated. Is that, it's the cue for putting weight on the heel or the toe? I couldn't work out whether it was meant to be early stance or late stance, because it feels like it should be late stance because your angle between the foot and the leg is small. However, I couldn't work.
You're saying a toes elevated single leg deadlift like Camporini style, so to speak.
Yeah.
So I think the reason why I like to use those cues, or really that constraint of the elevation of the foot, is because there are no cues, because it takes care of itself. So if I'm here, my shin angle, if I have a weight here, is now vertical. It's more vertical on this side, so that's going to be a mid-stance bias. Also, the weight on my toe is going to elongate my foot, so I'm going to be biased towards pronation as well at this point. Hopefully you guys can hear me. Can you guys hear me okay when I'm away from you? Okay. So I'm here, my foot's elongated, I'm in pronation, I have a vertical shin. If I go into a deadlift, then I'm naturally going to have my weight posteriorly translate back. So I'm going to couple internal rotation, pronation, dorsiflexion, all these things with this constraint right here. But if I were to flip it and do the opposite, then I'm going to be biased towards more early stance, more of a negative tibia angle at first.
Yeah.
If I wanted someone to get, for example, more weight sensing going into their heel and bias them towards early stance, I'd probably do more of a heel elevated. If I wanted more of a pronation coupling with internal rotation, I would do toes.
And then, so I think the video that you'd shown, it was you were holding the weight, so on the ipsilateral side, so the same size. Whereas when you went there, it was like going across your body, which is obviously for more internal rotation, you'd go contralateral, right?
Generally, yeah. The ipsilateral thing I think is effective for, on a hinge in particular, same side load is going to help you kind of drive a pivot around that back hip so you can get into internal rotation better on that, but also it's going to force you to drive out of internal rotation back into external rotation. because of that load pulling you into internal rotation. It's the same
Okay.
thing for rear foot elevated split squat with the same side load. You would be having, it would be pulling you into IR in that hip, so you'd have to drive out of IR back into ER. And then a contralateral load will help you shift into that hip more effectively, but there's less of that need to drive out of it because it's already pulling you out of it.
Okay. Cool. Good. Couldn't get my head through what that was meant to be doing, but it makes sense. Cheers.
Anything else?
I got a question, Connor. It's two things. So one is, if you're looking at like the position of the spine, like side bending, rotation, flexion, extension, like how does that affect breathing? Can you use that to drive air in different places? And I think I also saw Alex Effer had a post about like the crab position, doing like breathing with like your hands behind your body. Like where would that bias air to?
Question. Yeah. So if I think the easiest way to think about a side bending position is like a 90-90 side plank. So I would use a 90-90 side plank, for example. This, and then here, tuck, breathe, I can reach up, do whatever. And this is going to turn on my left oblique, obviously, and gravity is going to be pushing down on me. So air is not going to be going into my left ISA region. It's going to be going into my left anterior rib cage and posterior. So that's what's going on. So if I want to drive someone expansion anterior to posterior, I would put them in that position, and that oblique will shut off air from going into that section. Think of it like a chamber system.
So that would be good for like a wide ISA.
Be huge. Okay. Yeah. And to answer your question about extension, humeral extension is going to open up the pump handle, and the crab position is also going to open up expansion below the level of the scapula. So again, if I get a crab, then look at what happens to gravity. Gravity is going to want to push down on me, and my scaps have to be pulled together here. So air is not going in between my scaps. It's going to go below the level of the scaps, because that's also where gravity is pushing down. But it's also going to go into more of my maneuvering area. So if I wanted to drive air into my uppermost rib cage, like 2T, T2, T4 area, I would use this.
Okay.
And also below the scap.
Okay, like posterior below the scap?
Yes. Yes.
One more thing I had about that is what's limiting airflow there? Because I didn't see like any muscles or anything, but I was curious. Like I know maybe lats if you're overly anteriorly oriented. Is there anything else there?
It's lats, back extensors, QLs, things like that are just pressing up against the posterior cage there and just preventing it. Yeah. Lats are a big one.
Okay. Thank you.
And a little bit more of an advanced tactic you can use, and I don't talk about this because I just try to keep things relatively simple, but since you guys are here, something you could do, you guys know like plate pushes like this? Like, you see bodybuilders do this.
Yeah.
You could do something like this. I wouldn't do it straight out because like that's kind of my shoulders just going in like that right there. But in theory, you can do this in a position where you push and then inhale and elevate like that. And then what you're going to do is you're going to get your lower pecs to engage. And then what you're going to have is as you lift up, all this stuff in your neck and also your upper pecs are going to elevate your rib cage. So in theory, you should get some expansion in your manubrial area because all that stuff is elevating it. Now, I wouldn't use this with someone on day one, but if you're really struggling to get someone to get air in this upper anterior rib cage, that's a tactic you can use. Maybe probably laying down would be best.
Okay, cool. Thank you.
In the slides, there's so for the secondary compensation for a wide ISA, the 4 common results are all upper body.
Yes.
And there's not. So
primarily.
whereas with narrow ones, it also had like a squat and the toe touch. Perhaps I can't remember which ones it was. Is that correct?
Yeah. The wide one is generally a rib cage, and so is the narrow. That's the thing. But the narrows have their pelvis affected more by it than the wides, and that's why you see they start to look more and more like each other the more you go along. So let's think about the wides. Remember, they go like that. The narrows are already like that, but they still have this posterior pelvic orientation. So they kick this stuff on, they get shoved here. So now they're in both positions. Now, after phase 2, both people are here and here. And then phase 3 would be bend the sacrum backwards, and it would be just kick on the rectus, and then you're compressed from every direction.
Cool.
Anything else? Are you guys working with anyone who's like super phase 3 tertiary compensations? Ryan, what's going on with them?
I think I have 2 actually. One of them, I just started working with him, and he's actually a pretty young guy, but he can't move well at all. He struggles with basically everything, and I was gonna try to get some videos and put it on the Slack channel. I'll try to get some measurements and put them on the Slack channel, so you guys can get an idea. And then another guy looks very similar to what you just mentioned. And you can really see it if you just look from the side in his spine, like his lower thoracic, upper lumbar is like very rounded. And then the rest is kind of like flattened out a little bit. So he's kind of sway backed. And he has a lot of issues with like hinging, and he can't squat very low either.
Yeah. That's what have you done with him so far?
I haven't done much because he has a lot of pain. So we kind of do what we can. But I'm trying to improve his movement as best we can, but I only see him once a week for 30 minutes. So it's kind of hard.
What can you do? Yeah, that's tough. Corey, I think you raised your hand too.
Yeah, I have a client that he's pretty much limited everywhere. And then when he gets past 90 in a squat, he starts to hip shift right pretty hard, but he barely gets to 90. We just started to get past 90. We never even noticed a hip shift until he got past 90. But I want to say it's been a few weeks since I've measured him, but I want to say everything is limited besides external rotation on his shoulders. But he's had a history of issues. His low back, he has had everything but surgery pretty much.
That's tough. When you see someone
for him, it's just, I've never been able to change range of motion. It's just mitigating any like irritations that come up.
For sure. Yeah. When you get someone who's older, tons of surgeries, that's when things get tough. Also, things get tougher if you guys have ever worked with someone who has had something removed from them, like, for example, parts of their pec or parts of their oblique or parts of their hamstring, stuff like that. That's when things start to get hard. And that's because you're no longer working with the standard human archetype. You are now working with something that's altered. And at that point, I would refer out, because you're no longer, like, these principles still apply, but they're harder to apply because you're working with someone who's, modified. So they still can work. It's just, it takes reps with that stuff. Anyone else have a question? Amy.
Okay. So one of my clients who does have tertiary compensations, she locks her knees really bad. And also it's very hard to get her to get into a hinge position. What she tends to do, she tends, when she wants to hinge, she pushes her hips really, really far back and rounds it, and almost like, rounds her upper back too, but she doesn't realize she's doing it. She doesn't realize that she's locking out her knees when she's standing straight up. She also what she does when we do single leg activity, instead of, if I don't direct her to put her arm in a certain way, her default is to put it on her hip. And I believe she does that. And she doesn't even notice that she's doing it. I believe that she does that because it's how she adapts to balance, for her body to balance in a single leg position. And if she doesn't have her hand like on that hip, then that's when like she will fall out of position. And so we have to do a lot of stuff that's by the wall or whatnot. So it's a really interesting, like she's a really interesting case. But yeah, I enjoy working with her.
Yeah, that is interesting.
Yeah.
The hand on the hip thing, you do see that a lot, and it's unconscious thing. I think if I were to do it and we didn't have that conversation we had right there, I would feel more comfortable doing that. So yeah, that makes sense.
She's like a typical like left AIC, like right BC pattern as well, but she does it on like both sides during single leg activity.
Yeah, that's kind of like a natural human response, I find, just to stabilize the hip because that's where the pivot is. Yeah. Raul, did you have a question?
Yes. How we relate the test we saw with the gait, with the stance, like where this guy is in the gait cycle? We should see something when if we are doing the test, we can assume what he or she will be in gait, or how it works.
Yeah, I can give you guys some stuff on that. So if I've got someone who's, let's just go base layer. Someone who's wide should be biased towards more pronated feet. Someone who's narrow should be biased towards more heel strike feet, more early stance. So big arches, big toes, probably sprayed out a little bit and nothing too crazy. Wides are going to have just like straight ahead feet. They're going to be pretty low arches. In the left AIC, the right arch is going to be higher than the left. Now, if you get to a secondary layer, because the wide is not, their pelvis isn't dramatically affected by it at first, you're going to see usually the same kind of feet. With the narrow, what you tend to see is they tend to have more of a late stance foot. What they often bypass mid stance because they never had IR in the first place. So they go to late stance. So their weight gets pushed forward onto their toes because the back extensors push them forward. And then you see the big toes that are, turned outwards like this. You might see bunions in these cases. And then when you get to the third layer, you start to see it's almost unpredictable because people do crazy stuff. But what I will say is you often see wides who get high arches and narrows who get low arches. And when you see a wide that has really high arches or a narrow who has really low arches, that's almost a certainty that they're in the last stage.
Okay. And so today I was looking at the split squats and how to use them in training. Mm-hmm. Based on I mean, I've seen like based on gait, you have the where you want to be with the split squat, but then if you are using the assessment and you want someone to counter rotate or bias to internal rotation or external rotation, how is it work? Like, should we do early, mid, or always early and mid, or you know what I mean? I know.
Yeah. So if I wanted to, I think, internal rotation and nutation tend to go together. So if I want someone to get internal rotation in a split squat, I'm going to bias them to spending as much time as they possibly can in that 60 to sort of like 90 or 120 zone, because then when they do a hip shift in that position, they're going to get adductor, they're going to get internal rotation at the pelvis and at the hip. And then they're also going to be spending time in that maximize internal rotation zone, which is great. So that's what I would probably do. I'd probably do some variation of a front foot elevated with a forward hip shift in that instance. That would probably be my go-to for restoring internal rotation. For external rotation, I would want to do something like a front heel elevated variation, for example, with more of a contralateral load in that instance. You could also do a rear foot elevated if you wanted to get external rotation, but make it more of a transition point from IR back to ER. So in that instance, if I did an ipsilateral load, going back to what we talked about with the Camperini, we would be going heavy into IR on the eccentric, and then we'd have to drive out of IR back to ER. So think about the foot position also as it relates to this. So if I have someone who has super late stance feet, I probably don't want them spending a lot of time in rear foot elevated positions. I probably want them to be biased towards more of a toes elevated position, because that's going to bias pronation and mid stance. If I have someone who has super mid stance feet, I want them to spend more time in early stance, so heels elevated positions, because that's going to bring them back. I wouldn't go late stance all the way back to early stance with someone right away in most cases, because you're going to just be skipping the internal rotation, which they're probably lacking. The exception to this rule would probably be if I've got someone who's just, for example, they need to squat deep and they need to get more hip flexion. Elevating their heels is not a bad thing. But generally speaking, I want them to spend more time bringing them back one step at a time, as opposed to making large leaps. Likewise, for someone who has early stance feet, I would not push them into late stance right away. I want them to be able to pronate first.
Okay, thank you.
Anything else? If not, we're going to get into the study guide, because I think the study guide has some good stuff in it this week, so that we can review these assessments. Going once, going twice. Okay, let's look at it. Come on. Why do you think most people have secondary compensations? I've never worked with one person who doesn't have a compensation. That doesn't mean they're full secondary, but most people have something.
General lifestyle, injury background, and what they've done as kids, I suppose, growing up, sports and stuff.
Sure. Yeah, that's really what it is. It's the same reason why I can't tell you this person gets an oblique orientation or a lateral orientation because they do blank. It's impossible to say because we don't know everything they've done in their life. So because of the constraints and the demands placed on their system, the body has to find what they need in order to succeed and complete their tasks. So yes. Why would it be problematic to address an underlying primary compensation before addressing a secondary? Let's say we've got a wide who is secondary layer, and we're like, okay, we're just going to treat you like you don't have this secondary compensation. Why would that be potentially problematic?
I'll answer.
Sure.
So you'd want to treat the secondary compensations because, well, one, generally they're made on top of the primary compensations. Sorry, my cat is trying to battle me. And then you want to target the larger muscles that are closer to the surface to correct before you target deeper muscles that are associated with the primary compensations.
Yeah, exactly. It's like eating a cake. If you're going to, take a slice out of the cake, you have to go through the top layer first. You could go for the bottom layer, but that's gonna be awkward and your cake's gonna look terrible after that. So that's one way to look at it. But that's exactly right. Okay, a new client comes to you with the following assessment, and they have a history of moderate to severe right ankle sprain. So that means they have more than a couple. You'll see sometimes people just keep spraining the same ankle over and over again. If this is on the right side, that can be potentially, both sides are problematic. So they're narrow ISA, they fail both sides of their obers. Their squat is 100 degrees of hip flexion, so they just break parallel. They palm the floor with their toe touch. Their knee to chest is much better on the left than the right, but they get a pinch in the right hip flexor area. Their straight leg raise is much better on the left than the right, so we've already got a red flag right there. Femoral IR is much better on the right. Femoral ER is much better on the right. And their upper body is looking a little bit less than we might expect if we're thinking about an underlying left AIC pattern. What I would usually expect to see is a straight leg that is better on the right, hip flexion that's better on the left, obers that is better on the right, HGIR that's better on the left, HGER that's better on the right. Expansion upper body is better on the left, external rotation measures are going to be better on the right in the upper body, and then internal rotation measures are going to be better on the left in the upper body. So this is not that. So what is going on here? What comes to your guys' mind? Clearly they're not in just a normal pattern, right? So let's start off with their primary, secondary, tertiary. Where are they? I know.
Are they tertiary?
I would say no, but if they were tertiary, all their measures would probably be really limited. But they're still, you know, getting 70, 90 degrees in their straight leg raise. Their flexion isn't super terrible. And they're not, you can tell they're not just compressed from all directions quite yet, but I would say they're secondary.
The feeling the pinch in the right hip flexor on the active knee to chest, that's a red flag.
For sure it is.
Absolutely. But I'm not sure why the hip flexor would be pinching.
So just in a normal left AIC, right BC position, look at what happens to the femurs, right? So if I'm here, I'm going to lay on the table and I'm going to do a hip flexion. Do you see that? I'm going to take my screen share off. Do you guys see that as I'm in this position right here, you would impinge on the superior medial border of the acetabulum if I get to 90 degrees of hip flexion. Whereas on the left side, because it's forward, it's no problem. But on the right side, this pinching occurs. I run into the rim. So if that's what you would see if this was exaggerated. So they have something that's pushing them over to the right more. But what is that thing?
The sagittal orientation?
Why would you say it's a sagittal orientation?
Well, let's see. So I need to check these. So the right hip pinch, some of the measurements are reversed, like the left straight leg raise is better. And like they're both better, which is not normal. I think that, I don't understand this very well, so I'm just going through it. The IR is better on the right side. Yeah, the rotation is better on the right side than the left side on the hips. And then that's reversed at least a little bit on the shoulders because its ER is better. And the flexion is both, the flexion, the adduction, or sorry, the flexion is better on the left side as well. So it seems to match up better.
Now, here, I'm pulling it up. So you say it's a sagittal orientation. Does anyone have an argument why it could be something else? Nah, because you're right. So the distinguishing features are that pinch in the right hip flexion. So this is a sagittal orientation indeed. And this person is basically just being pushed like this, like that. So that's sagittal. And you can see how that would really jam that right hip in. And then you're really going to have problems in hip flexion. Whereas the left side, you're so far over here, you can just fling that guy back.
I had a quick question, Connor. I feel like one of my clients might be like this. So would this person have, I'm trying to think right now. So is this someone who's, because this person, like your example person, has the ankle sprains on the right side, so they've shifted back over to the left? Is that part of it?
Yes. So they're trying to probably seek a strategy to get themselves back into the left or restore missing hip internal rotation on the right because they haven't been able to be in their right side, but they want to be in the right side because they're a normal human being.
Okay. Gotcha. When would you see like a difference in adduction, or like that one hip would look more abducted than the other, maybe when you're just like lying down, you're doing exercises?
Are you saying like just visually speaking?
Yeah, visually speaking.
What you might see is you might see like because you're being pushed like this, the left pelvis is going to come down a little bit. So you actually still might see a slight degree of right hip hike, but you're going to see these underlying things.
Okay.
So if you were to palpate if you were to palpate their pelvis and kind of feel for what's going on, like for example, in the PSIS area, and then kind of feel it out a little bit, you might feel that you have to push a little bit, because remember, everything I do with this pelvic model right here, and to wrap up my thought, you might feel this is a little bit deeper. Everything I'm doing with my pelvic model right here is so incredibly exaggerated. Like when I do this, that's not at all what's happening within the actual pelvis. In reality, the left AIC is like this, and a wide is like that, and a narrow is like that. It's so subtle, but I could never do that and illustrate it that way. So I exaggerate the crap out of these pelvic movements. So really a lateral orientation might look like that, but it's just enough to affect the outcomes that we're talking about. Because the SI joint doesn't really move that much. Okay. So we'll talk about what we do with these people next week. So I just want you guys to be able to identify right now.
I have just a quick question. Can you have sagittal orientation, but instead of having a pinching on the right hip flexor, you can have a pinching on like the left hip flexor?
In a sagittal orientation, probably not.
Okay.
But you could, I guess in theory you could, like let's say their left hip flexor is still just like, you know, it's tight, but you know, they have this on top of it. I could see a situation where they feel both hip flexors, or they feel like, because they're going to say it's their hip flexor, but it's not really their hip flexor. You know what I mean? So it's really like that deeper area. So I think, yeah, you could feel both, but they're going to feel the right one more.
Okay. Thank you.
Mm-hmm. Okay. A new client.
So,
oh, go ahead.
So with the sagittal orientation then, so if the force is coming from above, so the back extensors, QL, etc., could that be where pain is? So could someone in the sagittal orientation potentially have QL pain on the left?
For sure. Yeah.
Okay. Cool. I'm just diagnosing my wife at the moment. Right. Cool. Good.
You could definitely have that.
Okay. Cool.
So this person has a leg length discrepancy, allegedly. So their left leg is shorter than their right. So I actually have a client. I wonder if I can pull it up. I've got a client who looks like this, honestly. Oh, no, this isn't it. It's this one right here. Assuming this loads. But you can see that that's not it. I think it's this one. Take a look at this. You see that? His left knee is literally higher than his right knee. So this is an example of something you might see in this situation. But notice how their right tibia is externally rotated. That right arch is still for sure higher than that left. And they have underlying themes of a left AIC, but you might look at this and have never taken this course before, just taken a PRI course and gone, it's probably a left AIC, but there's something else going on here for sure. So with that in mind, this is their assessment. Wide ISA, fail right, fail left obers. Their squat is, you know, a hingy squat like you might expect to see. Their toe touch is a mid shin, meaning that they can nutate. Active knee to chest is dramatically better on the left than the right, like dramatically. Their straight leg raise is better on the right than the left. Their femoral IR is pretty similar, but not great on either side. Their femoral ER is much better on the right. And their IR is, you know, not great at all. Their ER is limited, and their HG flexion is better on the left than the right. What is going on here?
So is that a lateral orientation of the hips?
What's your argument for that?
It matches the distinguishing features in the slide deck.
Yeah. I tried to make these not too difficult at first, but yeah, that's, and what are the distinguishing features?
Yeah, so it's the active, yeah, so the right active knee to chest being less than 90. And yeah, so left hip IR being greater than right IR. Is that right?
Mm-hmm. Mm-hmm. Yeah.
Sorry, I'm not sure where I'm seeing that. So if left hip IR is meant to be more than right hip IR. So where have we got that?
I had to throw you guys off a little bit because you will sometimes see things that work. Because again, these things are not 100% accurate all the time, but most of the boxes are checked here, and in a dramatic way, like a significant way. I would say, this guy has a lateral orientation. So
and it also makes sense logically when you look at it, right? So if that's up one, then it's pushing him. You can see he's moving client's shifting the weight over to the right, which kind of makes sense with that side of the hip being up. Therefore, yeah, exactly. That's why the knee's higher on the left.
Exactly. Yeah. So you might, and then traditionally, and this is a little bit, or for sure, almost beyond our scope of practice, do you say someone has a leg length discrepancy, just as, personal trainers and strength coaches? I don't think we should go down this path, but if you see someone where it's like, yeah, my doctor told me I have a leg length discrepancy, I have a shoe lift within the insole or whatever, then that's like a Band-Aid. And I can see how, from the doctor's perspective, that would be a quick fix, but it's usually one of these orientations going on. So here is where this pelvis is. Now you can see that again, you're going to pick up some right side internal rotation, but because you're not necessarily being pushed forward like this, you're still going to be able to access that straight leg raise on the right. But for example, on the left, if you're looking at that active knee to chest, you're going to still have a predisposition to be able to roll on the table because you're starting in a rolled position and get more hip flexion. Any questions on the lateral orientation? Yeah.
Sure. Okay. So I'm going to ask a really, really dumb question. So now you've posted femoral IR and femoral ER measurements. And I'm just like, oh my God, did I miss that assessment that measures that?
It was in the optional assessments at the end, because I don't think it is a necessary assessment unless you're like, you really need to determine if something like this is going on.
Okay. Yeah. I was like freaking out for a little bit. Just like, oh my God, I like didn't do something right. So
yeah. No, you're good. There's a couple different ways you can measure it. Some people do it seated, some people do it, supine, prone, whatever. But the reason why I didn't include it in the necessary tests is because if you've got someone who's got one of these orientation issues going on, you wouldn't address it right out of the gate. You would clear them bilaterally as much as possible. You'd want those other measurements to clear up. And if they're still having issues, then you would use those other optional assessments to dig a little deeper and find where this person is really oriented. But regardless of who you're working with, doesn't matter how old, young, or whatever they are, clearing them bilaterally first is always the first step.
Connor?
Mm-hmm.
I have a case that I was doing the assessment yesterday, and he has a left hike. So then I went to look at the two orientations you gave us that we could see a left hike, and it didn't fit in any of those. So I was like lost on what's going on here.
I think if you were to, is this a new client or someone you've been working with consistently?
New client.
New client?
First assessment, yeah.
Yeah, I think if you clear them bilaterally as much as you can, you're going to unwind them, and you're going to find that they're probably going to fit into one of these categories more or less, because right now they have a bunch of bilateral stuff going on, which is sort of masking, for lack of a better term, the underlying pelvic orientation issue.
Okay.
Yeah. Okay. A baseball pitcher complains of right elbow pain, which is his throwing arm, with the following measurements. Wide, Obers, he passes his right, he fails his left. His squat is not too bad. Toe touch is full. He's not pumping the floor or anything. Active knee to chest is better on the left than the right. Straight leg raise is pretty symmetrical. Femoral ER, honestly, this guy doesn't check out too bad, right? So is this guy primary or secondary or tertiary? I'd say he's certainly primary. I don't think this guy has anything going on that makes me concerned. Within his pelvis right away. Like, obviously we'd like to clear up some things, but is it the end of the world? No. Upper body now, IR is super limited, especially on the right. HEER is totally full. HE adduction is more limited on the right than left. This is kind of what you would expect to see within a wide who's got a little bit of additional compensations going on. So just because his pelvis is looking good doesn't mean his thorax is going to look that wonderful either. But what you will often see is hip flexion that matches the upper body flexion. Oftentimes these two measures are very, very similar. In fact, I'd say in 90% plus of cases, they're very, very similar. Now, if you see something that's totally the opposite, then you know they have something additional going on, like a pelvic orientation issue. That's just a little tidbit for you guys right there. So what is going on with this right elbow? What could be going on? Why is his right elbow taking so much stress? So right away, what are the big red flags in the assessment?
Limitation of the IR. Upper body, yeah.
So how could that potentially affect the forearm if we're thinking about the slides from this past week?
They're needing to pronate the forearm in order to make up for the internal rotation that they're not getting.
That could be it could be one of the things, right? So scapula is more winged out in a normal human orientation. The forearm is going in like so. The humerus is going into internal rotation. So what you can see at the forearm is that comes in with it, and they have to overpronate the forearm. So then you've got something going on where the forearm is in relative IR. So this can be a little bit confusing, but the forearm is in more IR than the humerus. So the humerus is in relative ER, the forearm is in relative IR, but both are biased towards IR overall. So then you would have like something that's the opposite of a knee valgus. You'd have that varus going on, right? The opposite thing you could have is you could have a humerus that's in internal rotation, and then we can't find ER, so we're going to find it at our forearm. We're going to torque out, then you have a knee valgus, but in your elbow. So you have relative IR, relative ER, because the knee is just the elbow. So with this person, we'd want to clear him bilaterally, and then we would want to make sure that that right IR is a priority right away. Making sense? I've got I would bet you guys, and you know, this is just my opinion, but if one of you guys just wanted to become a specialist in baseball pitchers, there's so much money to be made out there. I've seen so many baseball pitchers who just have terrible shoulders. Give them a couple of things and they're so much better. So if you guys want to make a killing, go work with baseball pitchers who, you know, have elbow issues. What exercise positions, supine, half kneeling, standing, etc., would be ideal to start a client with neck pain? That's tricky. There's no wrong or right answers here, really.
Not supine?
Not supine. Yeah, why is that?
Because they want to like kick in their neck because they can't get the anterior expansion, so they use their neck for that. And then since they're down, the air is even further like driven down. So it's just making them worse at what they're already bad at.
Mm-hmm. They're going to feel like they're choking a little bit. Yeah.
Would it be like sideline?
Yes, Amy, that's probably my number one. And what else could be good? I would say prone rock back. And I didn't expect you guys to get that, but the reason being, if you can just get like a child's pose sort of position and then rock back like this,
maybe even if you got someone who's dramatically limited, you just support their head like this and then breathe in that position. And then there's no stress.
You can get people in some interesting positions. Standing would also probably be okay. So something like a standing wall press where they're here, pushing back right there. That would be okay. Any other positions? There's really no wrong answers. But I will say, and this is a little preview of next week, if you have someone you don't know what to do at all, you have no clue what's going on, you have no clue where to start, just put them in sideline and you'll probably have some success. Sideline, 90-90 hip lift variations, stuff like that is good, even with head support if necessary. All right, guys, do you have anything else? We still have 7 minutes if you guys want to hit anything. Doesn't have to be related to this. It can be about anything you talk about, your dog.
Can you hear? No.
What's up?
Can you hear me?
Yeah, I got you.
Okay, sorry, I have one question.
Sure.
I have this case, which is really confusing because this guy has a narrow intercenter angle and he has been always active athlete, a swimmer. And a few years ago, he had, sorry, my English is not perfect, so bear with me, please. A few years ago, he had a very bad ankle sprain on the right side, right? He has been talking to some different practitioners, and I have been kind of working with him lately. I have not yet used these techniques, right? But there's something really confusing because I have studied some stuff from PRI, but they do not convince me a lot. Like one of the things is that they are always talking about the weight being on the right side, right? This guy has the weight on the left side. You can clearly see that. When he's standing, he's just like this. I don't know if you can see me. He's always like this.
Yeah, for sure.
On the left side, right? And then he has a remarkable lordosis on the spine, right? Anterior pelvic tilt. So I was kind of confused. And if you look at his chest from behind, you can see that he has a small rotation to the right side.
So he's like this and then like that.
On the right side, he's kind of bended and rotated.
So he's in his left hip, but rotated like that.
Exactly.
Yeah. I think this makes a lot of sense. Well, first of all, your English is very good. So I just wanted to let you know that. But also, think about that right ankle sprain. So if he can't sit in his right hip anymore because he had that dramatic ankle, it's just like the person we just talked about up there. They still have this underlying right BC issue where they are side bend to the right. Now maybe he's been so far over to the left, so he's thought a strategy to get back to the right, and that's by doing that. Or he was already in his right side and he couldn't be in his right side anymore, so he just shifted to the left. Regardless, I would clear him bilaterally. And if he still can't shift to the right at all, then I would consider giving him a right side. I would consider giving him all those PRI exercises, but just flip-flopped in the pelvis, like a right adductor pullback, a right hamstring, things like that. That would probably help if he has no ability to shift into his right at all. But I would also probably think about doing it on both sides, especially if he's narrow, you know what I mean? So maybe an adductor pullback on both sides and maybe sort of like tailor it more towards the right side over time. And then once they're even, you're good.
Yeah, sorry. He's always complaining about something, which is kind of interesting. He doesn't feel too much his right calf, right hamstring, right glutes, right chest, just everything on the right side.
Yeah. Everything hurts on the right side?
He has no pain, nothing.
That's amazing. Okay.
Yeah.
Yeah, this is why posture is not correlated with pain.
Just one thing. When he goes into hyperextension, right? Like imagine you are doing a bridge, okay? When you're doing a bridge, he feels pain around L4, L5. That's his only pain when he's going into bridging. Nothing else.
Yeah, he's probably just compressing that back as he's going into extension and just
Exactly.
So I think his glutes are probably real tight. He sounds like he's got tight everything that a narrow would have that's tight. You know what I mean? So I think just getting this guy the ability to bilaterally clear, give him all the basic stuff we're going to talk about for narrows on Monday, and then see what happens. He probably after that needs the ability to open up his pelvic outlet a little bit and, get those glutes to shut off a little bit. So after that, then see what the asymmetries are. And I would bet you that they're going to look better because you're going to clear them a lot of this unwind. They're going to unwind a lot of the stuff he has going on. And then if he's still sort of like leaning over to the right, pull him in his right and then go from there.
Thank you.
I was just going to say that when we talk about like we have to shut off like the primary like this more surface muscles that lead to like secondary and tertiary compensations, and it's really hard to do that. What I've had some really great some good luck with is the using sandbags or any kind of like weighted material that allows like that part of the body to relax or to just shut off so they can feel other parts. And it's more so with the clients who have like tighter necks or like tighter like traps. If I do put them in a prone position, I'll have them elevate their legs on like a couch or a chair. So the back of their calves is supported. Their femurs are going downwards, like into their hips. And what I'll do is I'll put like a neck roll underneath their neck and then place sandbags like on their shoulders, and it allows their neck to be more released. And also I place like 2 sandbags across like the hip points. As well. And the change in like their breathing is phenomenal actually. Like and like if I do that, and then but also it increases like there's an increased range of motion. Also, like they can not just have longer duration of inhalation, but better like holding of the breath, better like breath retention, longer breath retention, as well as a longer exhale. Too. But that's just been my experience.
That's a really good tool. I'm glad you said that because that is a tool. If nothing else works, just sheer force, can be a good way to go. And other things you can do is lie them on their side. Like Pat Davidson talks about this, put a sandbag on top of their pelvis on a sideline position. And if they're narrow, that can help literally just take them here, wait here. Now they're there. I had one guy in my last group who he said nothing helps his pain except for when his wife sits on his hip for 15 minutes while they watch TV, and that just decompresses him. So sheer force can be a good way to go sometimes. But it's 10:31, guys. We got to run. I've got another call. So thank you guys for coming today. Thank you for sticking around to the end, and I will talk to you guys on Monday. I'm taking advanced integration this weekend. I'm considering having like a little talk and just separate from anything we do with the group of just like, hey, this is what I learned. This is some cool stuff, but I also don't want to confuse you guys a lot. So if you guys are interested in that, let me know because I think it'd be cool to share some of that. All right. See you guys.